So JAMSS is actually an acronym, and it stands for Joint and Muscle Sprain and Strain. And although I know it's a really strange name, I did not come up with it. JAMSS is what the way we describe an acute episode of TMD. So if someone comes in and it's their very first acute symptomatic episode, whether it has to do with their joints or with their muscles, that's called a JAMSS episode. And what we're going to talk about today is the JAMSS protocol. And there's actually 3 parts to a JAMSS protocol. And the 3 parts are the initial JAMSS assessment, as well as the initial assessment of what you're doing from a standpoint of your procedure that you're doing, as well as then thinking about how to put that together so that you get the total assessment. I'm going to actually go ahead and type the code back in, everybody. Give me 1 second, because typing and talking simultaneously is a skill. Okay, everybody should be able to see the start code now if you open up your chat box. So when we think about occlusion, one of the things that I will tell you for me, I've taught occlusion for almost 2 decades now. And one of the biggest challenges for me when I think about teaching occlusion is helping dentists implement it in their practices. You know, in my practice, every day we do a caries risk assessment. I can't think of a patient who walks in our practice, whether they're a new patient or they're a recall patient, and we don't think about what their risk factors are for getting decay. Same thing with perio. We've done a risk assessment, a comprehensive periodontal assessment for too many years for me to remember in my practice. And you get an initial idea of what the person's risk is, and then you and the patient together talk about what I like to refer to as management strategies, things designed to reduce their risk so they get cavities less often, so that you're having to worry about bone loss less often. But this concept of applying that from a standpoint of occlusion or functional risk isn't something that's as routine. I think most of the dentists I know have a caries risk assessment protocol they feel really good about in their practices. And the same thing with periodontal risk. Now, that's not always been true for perio. I graduated from dental school in 1988, and in those days we did something called a PSR, a periodontal screening and recording. Today we do a comprehensive periodontal evaluation. But going back and implementing a system for occlusion has always been challenging. And the reason it's challenging is for years and years and years, when I taught occlusal risk assessment, it's something we focus on quite a bit in our Essentials 1 course at the Pankey Institute, and then we go back and talk about management strategies for patients at higher functional risk in Essentials 2. We teach a comprehensive joint, muscle, and occlusal exam. And we teach that exam, and you learn that exam, and the challenge is to say, I've got to go home and I've got to do this whole new additional piece to my new patient exam, thinking this could take me 15 minutes, 30 minutes, maybe 45 minutes, depending upon the complexity of the patient. How do I add that back to my new patient exam process? Oh, and by the way, I also can't change my fee for my new patient exam. And so it's those systems pieces, I think, that have always gotten in people's way from a standpoint of doing a functional risk assessment. So what happens, or at least what I've seen happen, is what happened in my practice when I first learned about this a long time ago. And I think it's what's happened in a lot of the practices for dentists that I've educated or that have come through our essentials at Pankey, is we go back and we have all of this great skill at doing a joint exam, a muscle exam, a functional exam, and we only apply it to patients who already have problems. So they already have signs and symptoms of TMD, or we're seeing such significant breakdown to their occlusion that we feel like we've got to jump in and say something. But the purpose of a risk assessment is to find people before they're symptomatic, before they have challenges, so that we can apply management strategies in the hopes that they never become symptomatic and that they don't have significant destruction to their dentition. And that's always been a challenge for me for years and years in teaching this and working with it in my practice. Because ultimately what we do want to know about the occlusion is, what's the current health of the entire functional system? So what's their current joint anatomy and health? What's the current situation going on with any destruction of their teeth from functional risk or any challenges with the muscles? But we can start that process by really figuring out who's at risk. So really, really fortunately, and if you've been to the Institute and you've been through the essentials in the last 2 to 3 years, you've actually already been introduced to a JAMSS protocol because we've only had it for that long. And so several years ago, 2 orofacial pain specialists, Dr. Brad Eli out of San Diego, California, and Dr. Jim Frickton from the University of Minnesota, came up with the idea to do a research study and see if they could identify a risk assessment that would take really less than 5 minutes and could be done by every dental office in the world to figure out, identify who the patients are at functional risk. And so when they were doing this, they reached out to me. They started a conversation with me. And I have to tell you, I was super skeptical because I thought there's no way they're going to find a 5-minute risk assessment that really helps us identify our patients at functional risk. Because I'd been trying to figure it out on my own for a long time and never come up with something. And they asked if I would help for a very specific reason, because they're both orofacial pain specialists. And so everybody in their practices already has TMD. They already have had an acute or have a chronic TMD issue going on. And what they needed was a patient population of just GP patients who they could have dentists try the risk assessment and see if what we could learn. And so between my practice, the piece of my practice that's GP patients, and then I happen to know a lot of general dentists who might be happy to participate in the study, we set about trying to see if we could come up with a JAMSS protocol. And lo and behold, what happened is I was completely wrong and Brad and Jim were right. And they came up with a really quick, easy screening assessment that helps us identify patients at risk of developing JAMSS, a joint and muscle sprain and strain. And so that's what we're going to go through. We're going to go through the steps of the screening and how we use it. And what we're really hoping to do by using this risk assessment is 2 things. We want to identify patients before they have significant attrition to their teeth, before they have lots of teeth with cracks and fractures or lots of restorative dentistry. We want to be able to identify the patients who are risking the long-term health of their dentition. We want to identify the patients who are at risk of having their restorative dentistry not be predictable, not have the longevity that we normally expect because they're at higher functional risk. And we also want to help identify patients who are at risk of ultimately developing TMD symptoms, whether those are muscle-based symptoms like tension headaches, muscle fatigue, challenges with eating whatever they want, all the way up to patients you might put in your box and say they have actual TMD or orofacial pain. So all the way from simply helping people keep their teeth for the rest of their lives in function, health, aesthetics without them having excessive damage to their dentition to true TMD patients, it all comes down to understanding their functional risk. There are people on the planet who are just tougher on their teeth, tougher on their stomatognathic system than other people. So just like you have patients in your practice who you'd probably swear don't own a toothbrush, but yet they never get a cavity. They have really low functional risk. And you have other patients in your practice who have meticulous oral hygiene, and yet every time you see their name on a hygiene schedule, you get apprehensive, wondering how many new carious lesions that you're going to have to tell them about when you do the exam. Same thing is true of perio. We really understand, and Sam Lau went through this really incredibly well on Monday in the webinar he did for us, that not everybody has the same periodontal risk. So true risk of periodontitis today, we believe is actually genetic. It's more like an autoimmune disorder. And so you have patients in your practice whose oral hygiene isn't great, but they will not suffer from bone loss. And other patients who are really awesome about doing what we ask them to do, and we're constantly tracking mucogingival attachment loss. We don't all have the same risk. Function works exactly the same way. We have patients in our practice who are at super low functional risk. I always like to joke and say, you could literally glue a penny to a second molar, ask them how their bite feels, and they'd go, great, great, I'm out of here. And you'd see them back in 6 months at a hygiene visit, and the penny would still be glued to their second molar, and you'd ask them how they're feeling, how they're eating, and they're like, great, I don't know, everything's fine. And I also have patients in my practice that literally can feel the thickness of the ink that is left behind on their teeth after I take the articulating paper out. And they'll say their bite doesn't feel right until you wipe the little marks off with a 2x2. And then the patients who actually develop true symptoms. So function works exactly the same way as all of the other risk factors we assess in our practice. And just like all of those other risk factors, the earlier we understand a patient's risk, the earlier we help them apply management strategies, then the less long-term damage they're going to have and the less long-term challenges they're going to have managing the issue. So we want to apply that same strategy when we think about function. So we said that JAMSS really is just kind of a complicated name that just describes the very first acute episode of inflammatory disease to either the joints and muscles. So it just stands for joint and muscle sprain and strain. So why even go into seeing if we could do a JAMSS risk assessment? Well, what we know about patients who have chronic TMD or chronic orofacial pain is two things. A very high percentage of patients that get into an orofacial pain practice, they see a TMD specialist or orofacial pain specialist, they're seen in an orofacial pain center at a dental school, and they have what we would call chronic TMD or chronic orofacial pain. A super high percentage of those people, between 60 and 70% of those patients, can actually identify specifically the first acute episode of discomfort that they ever had, or they can identify their JAMSS episode. They can tell you when it happened specifically, and they can tell you what they think triggered it. And of all of those remembered JAMSS episodes, about 50 to 60% of the episodes were actually a dental visit. So what the patient believes triggered their TMD or their orofacial pain was an actual dental visit. And so I am here to tell you that dentists don't cause TMD, dentists don't cause orofacial pain. But dental visits happen to be stressful to the joints, and they can be stressful to the muscles. And if we have a patient who already has underlying risk, they already have anatomic change or damage, they already have any inflammatory issues in their joints and in their muscles, and then we do a pretty traumatic procedure, what happens is we become the straw that broke the camel's back. We are the tipping point that causes that first acute symptomatic episode. And unfortunately, once you've had that acute episode, and especially if it isn't treated promptly and managed appropriately, the odds of developing a chronic TMD or a chronic orofacial pain are also high enough that this becomes a concern. So what the JAMSS protocol lets us do is identify the patients before they have that acute episode, and then it gives us some management strategies to prevent that acute episode from happening, and some advice on how to treat that acute episode if it does happen so that patients don't develop chronic TMD. So if we think about it, what Brad Eli and Jim Frickton really set out to do was put themselves out of business. So find a screening tool and a protocol that prevents people from developing chronic TMD so that they don't end up in both of their practices. And spending enough time with the two of them and other people who have orofacial pain practices, once you have a chronic orofacial pain or chronic TMD, there isn't treatment. There are management strategies, and some patients are better managed than others. But one of the things you help patients do is come to accept the fact that this is just a part of their life and that they need to really learn to appreciate the days they feel better, because it's not realistic to think about not having this anymore. So stopping it at the front end is really a phenomenally good idea. So it's going to go back to doing a risk assessment. And so we're going to walk first through the risk assessment and what are the things that we're going to do in a JAMSS protocol. Now, I also will refer you back. If you want to read about the original science, you can do that. So if you go to the Journal of the American Dental Association, there are two parts, part 1 and part 2. That is the peer-reviewed publication of the original study and the science. And then you could also go, you could read the, I think, easier to read article that we published in Insight Dentistry about the JAMSS protocol. And so I will answer that question. George Warga posted a question in the chat box. And did I say dentists are the tipping point for TMD, but don't cause or initiate it? Absolutely. Because George, if you have a patient who has healthy, happy joints and healthy, happy muscles, they did not present originally with functional risk. And the primary cause of functional risk, by the way, is one of two things. One is macro trauma, previous car accident, previous sporting injury, previous injury, head and neck trauma, or micro trauma, which is better known as parafunction. If you have a patient in your office who has happy, healthy joints, happy, healthy muscles, happy, healthy teeth, and you do a dental procedure on them, you're not going to trigger a JAMSS episode. Right? But if you have a patient in your practice who already has underlying anatomic change to the joints, they already have inflammation in the joints, they already have stretched, strained, inflamed elevator muscles, and then you do a more traumatic dental procedure, the more they already have underlying damage or inflammation, and the more traumatic the procedure is, you put those two together, and the higher the likelihood that you're going to trigger the JAMSS episode. Okay, and so the follow-up question was, what about the ortho patient or an adolescent who never had signs and symptoms? So that's a great question. So how many of us have had a patient who went to have their third molars removed and comes back popping and clicking? Darn it, what's with oral surgeons? How many of us have had a patient that goes to have orthodontics and comes back suddenly with brackets and wires and they're popping and clicking? Man, orthodontists do it too. But I could also ask, how many of you have had a patient who literally starts to pop and click after a hygiene visit, or literally starts to pop and click after they sit and they have in-office bleaching? Okay. That patient had underlying joint issues and probably muscle issues. They already had underlying changes to the anatomic structures in the temporomandibular joint. They're already loading the joint and loading the muscles with greater force than other patients. So the extraction of the third molars and the ortho or the hygiene visit didn't displace a disc. The disc was already at risk of that happening, and it could have happened yawning, opening to eat a triple-decker sandwich. There's lots of things that suddenly cause people to start popping and clicking or suddenly initiate symptoms. Now, having your third molars extracted, as you'll see when we get to procedural risk, is one of the higher risk procedures. So it is a riskier procedure if the patient already has underlying risk factors than a hygiene visit. But it really is about underlying risk factors. And what we're going to do is we're going to use a quick, easy assessment to figure out who are the patients with those underlying risk those risk factors. So a JAMSS screening starts with a series of questions, and then there's one and only one thing that we have to do clinically that we're not already doing. So this is actually the JAMSS risk assessment. This is actually the graphic out of the articles. I don't know if we can actually get you the link for those articles simply because it's hard for me to pull a link up while I'm lecturing. But the Inside Dentistry article is really simple to find. And it literally is just called JAMSS protocol, JAMSS, all capital letters. And the other two articles were in the JADA, Journal of the American Dental Association. So this is actually the screening questionnaire. And the other thing you can do actually, Brad Eli is also the inventor of a device called the QuickSplint, which we're going to talk about. And you can go to his website, quicksplint.com, and there's a reference section. And under the references, I believe he has those articles there and they're available for download. And this questionnaire is there. So this is the questionnaire that that is part of the actual protocol. Now I'm going to tell you right off the get-go, I do not give this out to my patients and have them fill it out, although that's what it's designed to do, to be a self-assessment. I actually ask my patient all of these questions. I do it in something that I refer to as a preclinical interview, and we'll go through this. And I actually also don't ask these exact questions in this exact way. So I'll invite you to either give this to a patient on a clipboard and let them self-assess. You can ask the questions exactly the way you see them right here, or you also can be creative and ask the questions in whatever way works for you. Right? And so the question about, do you often have jaw or facial pain? I don't usually ask a question like that. It's really common for me to have patients who, I expect patients who have TMD already think they have a diagnosis. They come and they tell you that. And I will ask patients, if they don't say anything about it, I will say, have you ever had any problems either with your jaw joints or your muscles? Has a dentist ever told you that they thought you have TMD? And I can ask that question. Right? Do you often have headaches? I ask my patients about headaches. I'm pretty specific, and the way I do it is to help walk the patient to giving me the information I want. So I do ask my patients, do you get headaches? And every human being on the planet answers it the same way. They go, of course I get headaches. And then I get to follow up with, how often do you get a headache? And now I listen for something very specific. I listen for whether or not the patient uses a very specific time frame when they answer that question. Everybody starts the same way and they say, oh, I don't know. And then some patients say, I don't know. And I get a headache sometimes when I have the flu or when my sinuses are congested. They don't have a diagnosis of headache. Other patients answer it by saying, you know, I don't know. 3 times a week. Any patient who answers a question about headache and gives you a very definitive time frame, in my box, has a diagnosis of headache. Now, there are lots and lots of reasons that people get headaches, and some of them have absolutely nothing to do with functional risk. So if they do give me a very specific time frame, I'll follow up and ask patients if they've had their headaches diagnosed by a medical professional. And by the way, it doesn't mean that it has nothing to do with functional risk, but it helps me understand their belief or their understanding about their headaches. But what we're asking that question for is to try to find patients who are overworking their elevator muscles, specifically their anterior temporalis, and maybe having symptoms they define as a headache. Okay. Now, the next question, 2 questions, is, do you have difficulty opening your mouth wide, and does it hurt when you open your mouth wide? I actually don't ask those questions because that's going to become part of my clinical exam. And when we talk about the one clinical screening we do, you'll see why I don't ask those 2 questions. Questions 5 and 6. Does it hurt to chew hard or chewy foods, and does it hurt after dental work? The way I do that is I say to my patients, can you eat anything you want, no matter how sticky or chewy, without your jaws getting too tired to finish, or you just give up because it's not worth it? And then I typically have to give them a couple of foods. So I'll say like a really chewy bagel or like a really inexpensive steak. And they typically will laugh. I don't use chewing gum, by the way, because patients have a belief that dentists don't think they should chew gums. So it's an emotional question. So I happen to use a chewy bagel and a really inexpensive steak. But I'll just ask my patients, can you eat anything you want, no matter how sticky or chewy, without your jaws getting tired or just having to give up because it's not worth it? The answer should be yes. You can eat anything you want. You can chew for as long as you want. And if the answer is no, and they say, oh, nah, I don't really eat almonds, or no, I don't do chewy foods, then that's a positive that they're experiencing muscle fatigue. And that's a finding that they have higher functional risk. And then I do ask my patients a version of the next question. I say, so can you come for a short dental appointment, like having your teeth cleaned or just having an exam, and be able to get through it without asking to close so that you can rest your jaws? That's how I ask that question. You'd be surprised when I started asking it, how many of my patients said to me, oh, I just take a couple Advil before I come. I go, really? Always before the dentist? Oh yeah, I've done it for years. I just take a couple of Advil because I know my jaw, my face will be sore after I go home when I have my teeth cleaned. And that's also a sign they're at higher functional risk. Okay. Question number 7 is, are your jaw or temple muscles tender when you press on them? I actually don't ask that question, and I don't ask it for a very specific reason. Because the instant I start to ask my patients about any of these questions, Patients who have sore muscles immediately answer you, and they don't even know they're doing it, but while they're talking to you, they're putting their hand on their face. And they're actually touching the muscles that are sore. They're touching the side where they have more soreness or tightness or tension. So I pretty much just watch their body language, and it already answers that question for me. Do you have aches and pains in your body? That's a great question, because what we're trying to look for is what we call comorbid diagnoses to TMD. So patients who have fibromyalgia are at much higher risk of developing TMD. Patients who have restless leg syndrome, believe it or not. Patients who have IBS. Patients who have rheumatoid arthritis. And again, I don't really ask that because those things are always on the medical history. So I already know. The only one that I ask specifically is about restless leg syndrome, because people don't think to tell you about that because they think it's insignificant. But I will ask my patients about those other diagnoses that tell me they're at much higher risk of developing TMD. All right, so question number 9 is, do you often notice yourself clenching or holding your teeth together? I actually don't ask that question. I don't, because I can look at their teeth and answer that question. And I actually know that when we ask people about grinding or clenching, they tend to get defensive. I'd stay away from saying to my patients, it looks like you grind or clench your teeth, or it looks like you have wear on your teeth. What I tell my patients is, you know, what I'm noticing is you're missing more tooth structure than you should be for someone your age. That's the way I describe tooth wear. Or I'll say, you know, it looks like you may just be tougher on your teeth than other patients. I'm usually referring to cracks or fractures. And I try to use language that doesn't move the patient into a place where they're going to immediately say no. Because if you say to a patient, it looks like you grind your teeth, they pretty much always say, no, I don't. And so now that shuts the conversation down. So again, my language is, you know, what I'm noticing is it looks like you're missing more of your tooth structure than I would expect for someone your age. Or, you know, it looks like you just may be tougher on your teeth than some of my other patients. And I don't have to ask the patient. They'll then say to me, oh, you know, I think I actually grind my teeth, or I think I clench my teeth. It's amazing how if you ask it in a different way or you approach it in a different way, you get a totally different response. Now you're open to a conversation. All right, let's talk about the last 3. Do you feel depressed, downhearted, and blue? Do you feel anxious or nervous? Do you feel like you have a lot of stress? Well, number 1, if you ask any American or North American, Americans, Canadians, pick who you want to talk about, and even before the last 3 weeks, whether or not they're stressed, I pretty much think you're going to get a 100% answer. And then depressed, downhearted, blue, anxious, nervous, I don't specifically ask. The first thing I do is I go look at the patient's medication list. So if the patient is taking a medication for depression, for anxiety, so they're on any SSRIs or any of the common drugs for that, I kind of already know the answer to that. And then my experience is as we start to talk about med history, those things will come up. So I don't have to specifically ask it. But anything from handing this to a patient and letting them do a self-assessment, asking each of these questions very specifically, or my version where I've personalized it and I do it as a preclinical interview, you just need to get the information. So patients who have had any previous joint or muscle pain, have probably already had a JAMSS episode, they're at higher risk. Any patient who has challenges opening wide, using their facial muscles, they're at higher risk. So all the patients in your practice right now, you know them, the people that you say open wide and they open, and then they go, no, 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 and you have to go, no, open wider, please. And then they go, no, 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 and you go, open wider, please. Any patient who cannot hold their mouth open long enough for you to do an exam or do a simple filling is already at higher functional risk. You know, any patient who can't open wide enough for you to work and you're searching furiously for the pediatric handpiece with the smaller head is already at higher risk. Okay? Any patient who, when you're working on them, their lower jaw is shaking up and down and you're really thankful right now you're working on an upper tooth, is at higher functional risk. Any patient where you see evidence of on their teeth of parafunction, so wear, cracks, fractures, already tells you they're at higher functional risk. So these are all people that in some ways we've kind of put in our box of, yeah, this happens, right? It's common, it's super common, but it's not normal. And those are findings of higher functional risk, and we need more information. And then there may have been some of the questions on here that are just new information. So before I switch slides, I'm just going to go over here and read the chat box really quickly. All right, I'm not going to read George's comment because it's really not a question. It's just so people can read it in the chat box. All right, so what are we going to do when we get chairside? There's only one piece of the actual clinical exam that we need to do for a JAMSS assessment, and that is we need to measure maximum comfortable opening. So this is really important. First thing you want to do is you want to measure the patient's overbite. So how much do their maxillary incisors overlap their mandibular incisors? And then you want to ask the patient to open as wide as possible comfortably. It's really important that you say comfortably. They should only open as wide as they can without they feel any tightness, tension, stretching, burning, tingling, discomfort. And now you're going to measure the distance between their upper and their lower incisors, and you're going to add it to their overbite, and that is their max comfortable opening. Okay, lots of different kinds of range of motion guides. So this is an autoclavable range of motion guide that we sell at the Pankey store, and you can reach out to Mark Hollis, and he has these in stock. They have disposable ones that you can get from Quick Splint, from Great Lakes. Panadent sells a really nice autoclavable range of motion guide. So there's lots and lots of companies that make range of motion guides. Today in my practice, I will tell you, we use the disposable kind. So we just use it once and then we toss it out. But if you like these, I don't know if it has a very fancy name, Greg. I think we just call them range of motion guides, but Mark has them at the Pankey store. And you're going to now measure that. And so what are you going to do? You're going to look at that max comfortable opening, and you're going to use the number. Anyone whose max comfortable opening is between 40 and 60 is normal risk from range of motion. If their max opening is greater than 60, they're at high risk. If their max comfortable opening is between 30 and 40, they're at moderate risk. And if their max comfortable opening is less than 30, they're at high risk of developing JAMSS. And yes, Greg, the answer is you can get those from Mark at the Pankey store. So we're just going to watch a quick little video here. And I'm hoping this stream is streaming okay based on everybody's internet. I'm just measuring Shelly's overbite. So I just marked where her upper teeth were and then measured that visually. I asked her to open as wide as she can comfortably without stretching, straining, burning, tingling, or discomfort. And then I just add the two numbers together, and that now gives me her max comfortable opening. And so what I'm doing now is I've done my JAMSS protocol. That's all you had to do was that conversation or that series of questions and that one piece of a clinical exam, which is max comfortable opening. So our hygienists do max comfortable opening and can ask those questions. Both of my clinical assistants can do that. I do it. I use the JAMSS protocol and these questions all the time in my practice routinely because I already know that what is going to be really important now, if somebody had any yeses to the questions, if their range of motion is greater than 60 or less than 40, I need more information, okay? And that more information is I now want to do a comprehensive functional exam. I do want to do a joint history and exam, a muscle history and exam, an occlusal history and exam, all of the pieces that we teach in Essentials 1. I do know that that more comprehensive functional exam takes me sometimes 30 minutes to an hour. And how can I do that from a systems logistic perspective? Well, if you already schedule enough time in your new patient exams to do that, then you can just incorporate that, and now you know to pay a little bit more attention because they've already told you from a JAMSS assessment they have higher risk. But if you're not already routinely doing joint muscle functional risk assessment on every new patient, every patient in your practice, then what you can do now is you can actually bring them back based on a JAMSS assessment, and you can use the CDT code for an exam that's called an extensive evaluation. And an extensive evaluation cannot be done the same day as a periodic or a comp exam, but you can do it on a different day and you can charge for it. We typically get probably good 60% of insurance companies will pay for an extensive exam. It is a problem-focused exam. And the problem was identified using a JAMSS protocol, and that's the reason for bringing them back and doing that more comprehensive functional exam, right? And so we did get a name for the triangle. We think it's called the TMJ tri-measure. Didn't remember that. Thank you, Keith. Post the range of motion, I will try to type it in here really quick while I talk. Guess I can't talk and type. All right, so there you go. So we got that one answered. And then what about teens and children heading to the ortho oral surgeon? Absolutely, max opening. Ask them about any previous discomfort or challenges in their joints. Ask them if they can eat anything that they want without their jaws getting fatigued. And look at the tops of their teeth. Anyone that I see evidence of parafunction, if I do see inappropriate wear, so they have more tooth loss than they should for someone their age, I'm concerned about that. So this JAMSS assessment works for teenagers, adolescents, also going over to the orthodontist or to the oral surgeon. Okay, I'm going to apologize, Nicole. I don't actually know the actual code for an extensive evaluation. If somebody who can pop on the internet can look that up, it is in the exam codes, but I don't remember it. We'll get it in the chat box for you. And then the last one was, what did you add to calculate that number? Add overbite to the distance between the upper and lower incisors when the patient is open comfortably. So what I do is I use a JAMSS protocol as an indication for then doing an extensive evaluation, comprehensive joint muscle functional exam. Now, what you can also do with a JAMSS protocol is you can actually bring the patient right back. You can move into your restorative dentistry or your oral surgery or your ortho, but now what you're going to need to do is you're going to need to do the second part of the assessment, and you're going to combine the patient's risk and the procedural risk. And so this is the second chart that goes with a JAMSS protocol or assessment. And again, you can find these right on quicksplint.com. Brad makes these available for everyone, and you can actually print them right off his website. And so what you're going to notice is that he's basically combined what you learned about the patient and then the procedure that you're planning, and together they have a low risk, medium risk, or high risk total score. And so anything that's on the mandibular arch is higher risk than the maxillary arch. The further back you are working, the higher the risk procedure. So working on a premolar is less risky than working on a second molar. The instant that you have to give a mandibular block, the procedure becomes higher risk. If you have to give more than one mandibular block, it becomes even higher risk. The longer the procedure, or the longer the time the patient is going to be asked to hold their mouth open, then the higher the risk the procedure. So now you can see why taking out 4 third molars is a very high risk procedure. And if you do it on a patient who already has risk factors, then you add the two together, and that's why we see patients come back from the oral surgeon and they're popping and clicking, or they have problems, okay? So you're gonna combine the data, and then you're gonna get a total risk assessment. So thank you everybody for getting in those codes so that we've got that. And then I will answer one more question. I understand why 30 millimeters is high risk, but could you please explain why 60 millimeters is high risk? So patients who can't open wide, so less than 40 millimeters or really less than 30 millimeters, are high risk either because their muscles are so contracted, so fatigued, that they can't open wide enough, and so you're getting really significant muscle evidence of their risk, or they can't open wide because they actually already have anatomic damage to the temporomandibular joint that's blocking its ability to open fully. But patients who can open more than 60 millimeters are high risk for 2 reasons. So one is they could potentially actually subluxate or open past the eminence. and then they can actually get locked out there during a long procedure, and that's extremely stressful to basically hyperextend the temporomandibular joint and then fire those muscles up, can trigger a JAMSS episode. And or the reason that over 60 millimeters is because they've already got some damage, anatomic damage in the temporomandibular joint that allows it to be sort of hyperextended. So hopefully that answers that question. So now you've done your patient JAMSS assessment, your procedural JAMSS assessment, and you've got a crown treatment plan, or you've got a quadrant of composites treatment plan on a patient, and you know there's a risk factor, or you've got that third molar extraction. So how are you going to manage this? Again, my hoped for would be that as soon as you saw the patient was at higher functional risk, that you'd bring them back for that extensive eval. You'd actually do a comprehensive joint, muscle, and functional exam, and that patient might actually benefit from true appliance therapy prior to restorative dentistry. But let's say you're going to jump right in, you're going to do that restorative dentistry. How do you minimize the risk of causing a JAMSS episode? Probably the most important thing you can do is fabricate a pre-op temporary appliance for the patient, and you're going to have them sleep in that appliance every night for a week or two prior to your procedure. And so the temporary appliance I use in my practice is a quick splint, again, designed by Brad Eli. So you know I don't get anything from quick splint. I just think of all of the temporary appliances, it's my favorite. It's quick and easy to use. I like it because since the part you reline with silicone goes from premolar to premolar or minimum canine to canine, it's very retentive. I don't worry about it falling off in the middle of the night, people aspirating them. It is a temporary anterior only appliance. And so what we'd like when we do this is the patient has even or symmetric contact right and left of the midline, but no posterior teeth come into occlusion with the plastic shell after it's relined. So just from canine to canine. Anterior only appliances do have some risks, and I know somebody out there is going to post a question about tooth extrusion, tooth intrusion, permanent occlusal changes. These are temporary appliances. They are relined either with bite silicone, and if you reline it with bite silicone, they self-destruct in about 2 to 3 weeks. Or you can reline them with VPS monophase or heavy body tray material, and they self-destruct in about 2 months. And because they are temporary, the risks associated with anterior onlys go down immediately. I would not make an NTI. That's not a temporary appliance. We reline it with methacrylate or composite. I would not reline this with methacrylate or composite or thermoplastic beads. It turns it into a permanent appliance. The simple fact that these are relined with silicone and they self-destruct is what allows them to be safe without ongoing appliance therapy management appointments, and we can use them for this specific protocol. So again, we're going to watch a little video of just making a quick splint. I don't do this with retractors, and that's literally just for the video. Here's the shell. The very first thing I do is I simply try it in, and then I have the patient close, and then I assess which teeth are touching. So what I'm going to do now is I'm going to actually come in here and say, am I touching canine to canine? Well, in this case, no, I've got a premolar touching. So there are 2 ways to do this. You can reline this first and then adjust it with an E-cutter in a straight handpiece if you want to, okay? Or what I do is I take it to a lathe and I actually just cut off the white plastic shell just past these little retention holes. And then I'll go ahead and reline it, okay? I actually will tell you the next piece of this is I'm gonna actually put tray adhesive in it. I don't actually do that anymore. I never reline these with tray adhesive, so that's why I'm speeding up through it. I've had patients become allergic to the tray adhesive and then they don't self-destruct very quickly, right? So I'm literally just gonna load this up with VPS material. You can use bite registration paste, you can use VPS tray material, either monophase or heavy body, and I'm gonna load it just up to the edges of the white shell. I'm gonna put it back over her upper teeth. Don't push it all the way up, just set it on there. And then I'm gonna actually let the patient close so that it is now self-leveling. I've allowed the material to fully set. That was edited out of the video. You're gonna pop it off of the patient's teeth. This is actually virtual XD. It's a heavy body tray material from Ivoclar. But again, do it with Bite Reg, do it with Monophase. And then just take out a blade, a 15, a Bard Parker, and now just trim off the excess material. I actually just drag it across the white Teflon to know where I should trim. I don't normally do this over the patient's mouth. That was just so that it was in the video. This center is so that you could add composite or methacrylate if you want to create a midpoint stop. Just make sure the silicone, their teeth don't drag across the silicone there. And then the little plastic case it came in is its retainer case. So you're just going to pop it back in there and send the patient home. And the instructions are brush and floss your teeth at night, put the quick splint in, sleep in it all night long, take it out in the morning, brush and floss your teeth, throw it back in the case, and they just wear it every night for the couple of weeks until they come in for their appointment. All right, so I'm going to answer a couple questions. Okay, so it says, because anterior deprogrammers are contraindicated in patients with intercapsular disorders, should you not use a quick splint if the patient has an intercapsular disorder? So not all patients with an intracapsular disorder is an anterior only contraindicated. Most of our patients who have a displacement of the disc are actually off of the lateral pole, and we go through how to differentiate a lateral pole versus a medial pole displacement in Essentials 1. If the medial pole of the disc is in place, then anterior only should work great. But if you're concerned about it, you could not do an anterior only. I will tell you with a quick splint, again, my instructions to the patient are, we make it for them. I have them sit in the office for 15, 20 minutes, and we ask them, how do they feel? And if they feel okay and they have no new pain or discomfort, we have them go home and sleep in it every night for 2 weeks. And what I tell the patient is, if you develop any new pain, new discomfort, anything you've not experienced before, take it out, stop wearing it, and call us. And you're doing this in a lot of times before you've done a comprehensive joint exam. Now, if you do a comprehensive joint exam on your patients and you already know they have a medial pole displacement, I would not put them in a quick splint or any other version of an anterior only appliance. Okay. Next question was, have you deprogrammed first before relining this? No, you don't have to, because it's an anterior only. They will deprogram on the device, and there's nothing in the back. So you'll not pick up any posterior interferences. So they will find centric occlusion and their condyles will seat on this device, and you can just have them bite in it anyway when you make it. Next one was, maybe you said this and I missed it, do you charge patients for the quick splint? So my fee for a quick splint is somewhere between $0 and $150. The quick splints themselves cost about $25 each. There's a discount if you buy them in bulk. And then if you tell Quick Splint you heard about it at a Pankey course, they'll give you a Pankey discount. We don't get anything, but they just like people who learn from us to get that discount. And I make a decision. I make quick splints all the time over anterior veneer provisionals. I don't charge for it. I'm charging for the provisionals. If I'm making the quick splint as a JAMSS preventive measure for a big restorative treatment plan, I probably won't charge for it. Sometimes I charge up to $150. There is a code, I think it's in the orthodontics section, that's called a temporary occlusal appliance, and you can use it. Don't bill an insurance company for a temporary appliance if you want to bill them for a final appliance when you do that. I don't know the code, unfortunately, but there is one. It's called a temporary occlusal appliance. You don't have to worry about MIP or CO because it's an anterior only. Just ask them to bite against the platform, and when they have it in, as their muscles relax, their jaw can go back into centric relation. They won't pick up an posterior interference, so it's not a problem. How do you get both canines to touch? Typically when I put it in, and I might have trimmed it, or because I don't push it all the way in, I let the patient self-level it. They'll self-level. But if you have a premolar contact after it's relined, pick up a handpiece with an E-cut or a straight handpiece, and just make sure you only have contacts from canine to canine. Yep, and exactly, Ganeshi. The only reason it just was a demo video. I would have adjusted it to get rid of the premolar. Okay. All right, so moving forward, okay, so we're gonna make a temporary appliance and we're gonna have the patient sleep in it every night for 10 to 14 days before their appointment. The next thing we're gonna do with that restorative appointment, if we can, is we're gonna do shorter appointments. So instead of doing an entire quadrant of dentistry, maybe do 2 teeth at a time and bring them back. The shorter the appointment, the better it is. The other thing I'm gonna tell you about patients who are at high risk is that they should not be put on a bite block. So when we do a bite block, first of all, we're doing it on patients who already are demonstrating they're at high risk. The fact that we want a bite block, that they can't open wide enough, that they can't stay open wide enough, tells us they're at higher risk in a JAMSS protocol. Now you ask them to open, you push the bite block, you say open as wide as you can, you shove it as far back as you can. So you are now hyperextending the temporomandibular joint and you're giving them posterior tooth contact that sets up a neuromuscular cycle with their elevator muscles, masseter, medial pterygoid, anterior temporalis, that actually increases the risk of developing JAMS, or joint and muscle sprain and strain. So shorter appointments if you can, or if you've got to do that quadrant of dentistry, actually make the appointment longer so that you can stop and give them breaks, 5-minute breaks, 10-minute breaks, let them close their mouth, ask them to bring their quick splint with them and put it in for a few minutes so that you can rest the jaw in between. And then this is a great isolation device that I will use when I can't use a bite block or an isolite. It's called Relief, capital R, little e, capital L-E-A-F, and it's made by Kulzer. It's a really soft version of a triangle that's connected to a high volume suction. The leaves are disposable, they're about $1. The little plastic piece you see holds it exactly in the buccal space. It's autoclavable. Then there's about an 8-inch tube that's autoclavable and it's shoved right in the top of a high volume evacuator. Super great way to do dentistry when you can't have somebody on a bite block and you need high volume suction. So temporary appliance, shorter appointments if possible, no bite block, or if you can't do a shorter appointment, longer appointment with time for breaks, and then plan for post-op management. And post-op management is a screening for JAMS symptoms. And so these are the symptoms of joint and muscle sprain and strain. And it can be acute jaw, face, or ear pain. It can be limited opening. They can't really open very wide. They have tenderness in their jaw muscles, or when they try to open, it feels tender. They have trouble eating normal foods. Their jaw gets tired or is tender. And so who needs to know what all these symptoms are? Whoever answers the phone in your office. Super common for patients to call after a dental visit and get whoever answers the phone and say, you know, I was just in there yesterday and I had my crown done and my face is a little bit sore and it's kind of hard to chew almonds right now. And the person basically says, oh, that's really common, and they don't bring the patient in. Okay, these are the symptoms of JAMS. Anything that whoever answers the phone would say, oh, that's a little bit of trismus, or that's normal. It's not. Those are symptoms of JAMS. And the more quickly and the more effectively we treat it when we do have JAMS symptoms, the less likely the person is to develop chronic pain. And here's what happens. Lots and lots of the patients who have a JAMS episode call their dentist and are basically told, oh, it's not a big deal. They then end up in the medical system at the ER or at a physician, and they don't understand how to treat this, and it's never properly treated, and they become chronic TMD patients. So anyone who's at moderate to high risk, if I had them on their quick splint before the appointment, I ask them to stay on their quick splint for another week or two after the appointment as a preventive measure. So the device that goes into the high volume suction is called Relief, capital R, little e, capital L-E-A-F. I'll type it in here for everybody. So it's called Relief by Kulzer, okay? And it goes right into your high volume. By the way, if you get one for your hygienist, because they are the best thing on the planet when they're using an ultrasonic. Now, I don't know that they control the aerosol under current circumstances. Would have to look at that. But previous to the last 2 weeks, my hygienists were in love with using Relief from a standpoint of when they're doing ultrasonics. So these are the signs and symptoms. If somebody develops JAMS, keep them on their temporary appliance. So keep them on their quick splint for another week or two, at night for sure. And they can wear it even during the daytime if they have to for a short duration of time. A short duration is a week, 2 weeks maximum, right? Anti-inflammatory medications. So ibuprofen, Advil, Motrin. I like them to do 600 milligrams 4 times a day. And I will actually write a Motrin prescription, 600 milligram Motrin, have them do that 3 to 4 times a day versus taking over-the-counter ibuprofen and doing multiple pills. I rarely, if ever, go all the way to something like a Medrol dose pack, but certainly if you had someone where you really thought they had some significant inflammation, you could do a Medrol dose pack. Hot or cold compresses. So I tell my patients you can do hot or cold, whichever feels better. And it's 20 minutes on, 10 minutes off, 20 minutes on, 10 minutes off. Why give the patient the option? Joint inflammation typically feels better if they apply cold. Muscle typically feels better if they apply hot, and they're going to be able to figure that out, and they can do whichever one seems to manage the discomfort and manage what they're feeling better. Soft diet, absolutely soft diet. I tell my patients scrambled eggs are not soft enough. So preferentially, if they can go to smoothies, they can go to yogurt, they can go to stuff that does not require chewing. And they're going to be on a soft diet longer than you think, several weeks potentially. And anything they try to chew that is uncomfortable or tires their jaws out is too much chewing, and they need to do something that's softer. Okay? And then at the end of this, once all of the discomfort is eliminated, then they're going to need to do a little physical therapy. And the physical therapy is by doing exercises. And there's lots of exercises. One is to ask the patient to put the tip of the tongue back on the junction between the hard and soft palate and open as wide as they can until they feel any amount of tension, and just redo that. And so the exercises, again, I'll refer you back to the Quick Splint website. They've got a really great list of exercises. You can print it out and you can actually give it to the patient. Right? So had a couple of questions come in, and we'll go all the way back to, can we recommend wearing the splint before they get a cleaning done? Absolutely. We do this for hygiene patients all the time. I have patients all the time wear a quick splint every night for a week or two before hygiene, and then they can put it right back in 6 months later and do the same thing. Since it's relined with VPS, even with a little bit of tooth movement, they'll still be able to get it in. They'll be able to open wider, they'll be more comfortable, and less risk of them having jams after a hygiene visit. Do I ever give Flexeril for acute muscle pain inflammation? I'm not going to say I never write it, but I don't write muscle relaxers as often as you would think. The muscle relaxation, that temporary appliance, that quick splint is going to give you more muscle release, more muscle relaxation than Flexeril will, without all of the sedative properties, without telling patients they can't drive a car, and without systemic pharmaceutical therapy. And when I do write muscle relaxers, I actually don't typically write today for Flexeril. I write for a muscle relaxer called Robaxin, is a brand name. It's a version of methocarbamol. They can take it day and night, and it doesn't have nearly the sedative properties. So patients like it a lot better. And so Melvin said, I've been told on previous TMD courses, moist heat. Your thoughts? Moist heat is great. Dry heat is great. If patients like heat, they should apply heat. If cold makes them feel better, they should do cold. And it really is, they can follow their intuition. And one of the things I would tell you to notice about this is these directions are no different than what somebody might tell you if you twisted your ankle or if you sprained your wrist. This is really basic joint and muscle acute inflammatory management. We're just applying it to the muscles of the face and to the temporomandibular joint. And I tell my patients that. I say, use the same intuition you would use if you twisted your ankle. If you twisted your ankle, you would not go out and run. That you've twisted your jaw joint, you shouldn't be eating almonds. That's the dental version of running on it. You know, you would take Advil over the counter. We're going to take it for this. You might put an ice pack on your ankle. We're going to put an ice pack on your face. It's very intuitive if you can help patients think about that. Okay. And we talked about muscle relaxers, and then lots of comments about the relief. It is awesome. I use them in my practice. I don't always put the quick splint on maxillary teeth. Sometimes I do put it on mandibular teeth. Sometimes it doesn't fit on one arch. You have to put it on the other arch. And you can ask the patient if they have a preference. I find it's less of a lip bumper on the upper than on the lower, but it doesn't matter either way, okay? How long do they take the anti-inflammatories and do the hot and cold compresses? I typically ask the patients to stay on the anti-inflammatories for 5 to 7 days. And if you've got a patient who can't take NSAIDs at all, so they have other pharmaceutical interactions or medical reasons, then I would do a Medrol dose pack. And again, hot and cold compresses, the same thing, minimum 72 hours, right? Why aren't these patients made definitive anterior guides? You know, if I was actually going all the way back to the way I do this in my practice, if I found risk on a JAMSS assessment, I would then bring them back in for an extensive evaluation. I would do a comprehensive joint, muscle, and occlusal exam. And based on that exam, I would do appliance therapy recommendations prior to doing restorative dentistry. This protocol, since we've started talking about procedural risk and now management, is for a patient where for some reason you're not going to follow that protocol of doing an extensive eval, and we want to go right to restorative dentistry, but we want to minimize or manage the risk of developing a JAMSS episode. So if you're already doing comprehensive joint and muscle functional exams and putting people on appliances, then you don't need the JAMSS preoperative protocol. And what I would tell you is I still sometimes do the post-op, because even on a long-term appliance, patients can develop a JAMSS, and this post-op protocol is really important. George, I don't use Valium. I haven't written a patient a prescription for Valium for muscle discomfort or parafunction in years and years. That doesn't mean it's not appropriate. I just don't do it. So I can't speak to that protocol, okay? What's my preferred type of long-term appliance? You know what? I use 6 different designs of appliances in my practice routinely, some more often than others. I teach a 2-day course called Occlusion in Everyday Dentistry at Pankey, and we spend a whole half day talking about appliance therapy and the 6 designs, what they do, what they don't do, and what clinical indications they're used for. So I do use anterior only. I do use full coverage anatomic on the lower. I use them all. It depends on the person's joints, muscles, tops of teeth. So hard question to answer without knowing some background. Yes, this video will be posted on YouTube. Everyone who's registered will get a link when Dylan has it edited, okay? Prescription that I use instead of Flexeril, again, the name of the drug is Robaxin. The generic name is methocarbamol. And then George supplied everybody with a little bit more information about Valium in case you're interested. I do Botox, George. That's a conversation for a different lecture, different webinar. I do Botox routinely for chronic pain patients who are already on full appliance therapy, and they don't get complete resolution on an appliance. And so I have a specific way that I use it, okay? And then nice comment from Mike Sherb. So you can read that. I think that's great for everybody. And I'm just trying to see if there's any addable questions for me. The list of the exercises is on the Quick Splint website. So go to quicksplint.com, okay? The disposable range of motion guides, Great Lakes Orthodontics sells them. Quick Splint sells those disposable range of motion guides. So they're pretty easy to find. And Amy, you've been so awesome. Amy, you get the gold star for web links today. So way to go, Amy Heim. And so now you've got that for the jaw exercises. All right, we are at the end of our time.